Let's get started. First, I'd like to say good morning. Appreciate everyone getting up today at 6:30 in the morning. I think that's typical for a lot of people, but not necessarily typical for everyone. Especially like to thank our speaker. He is in Wisconsin, and so he's an hour different than us. So it's 5:30 his time. Today is the second in our sports sciences lecture, and I think you'll find it very interesting, relevant, and important, especially if you take care of athletes or if you take care of anyone who's doing any kind of high speed running. Uh, Before we get started, I'd like to thank the Musculoskeletal Institute here at Atrium Health for their support in this series of lectures. Especially like to thank Dr. Moorman, Dr. Seymour, and Dr. Danielson. I'd really like to thank Susan Colston for helping with the logistics, because that's really the essential aspect of actually getting this done this morning. We are being recorded, just so you're aware. Before I introduce our speaker, I'd like to outline the format for today's presentation. So we'll first start with the presentation, and that will be followed by Q&A. You can post your questions in the chat room, and I'll keep track of those, and I'll monitor those, and I'll ask those questions at the end. There will likely be an opportunity for you to raise your hand at the end of the lecture, and so you can ask your questions verbally. Again, this lecture is being recorded. So without further ado, I'd like to introduce Dr. Bryan Heiderscheit. I've known him and have circled around with him at the combined sections meeting now for probably 20 to 25 years. He's the Frederick Giesland Professor in Orthopedics and Vice Chair of Research for the Department of Orthopedics and Rehabilitation. He's the Director of the Badger Athletic Performance with University of Wisconsin Athletics. And in my opinion, it is likely the best example of how an academic institution, an academic research laboratory can work with a department of athletics or an athletics department, and how he does research just like a lot of us like to do. Is we do research for the student athlete, not on the student athlete, and we don't use the student athlete to do research because we have another study going on. He's also the founding director of the University of Wisconsin Health Runners Clinic and co-director of the University of Wisconsin Neuromuscular Biomechanics Laboratory. His research is aimed at understanding and enhancing the clinical management of orthopedic conditions, with a particular focus on sports-related injuries. He's had support for his research from the NIH, the NFL, the NBA, and GE Healthcare. He's the senior editor for the Journal of Orthopedic and Sports Physical Therapy, and serves on the editorial board for Orthopedics Today. He is a fellow of the American Physical Therapy Association, past member of the executive board of the American Academy of Sports Physical Therapy, and is a member of the NFL Soft Tissue Injury Task Force. And with that, just would ask everyone to make sure they are muted, and I will hand over the lecture and the microphone to Dr. Bryan Heiderscheit. Thank you, Bryan.
Thanks, Tim. Really appreciate that, the introduction. And again, thanks for organizing everything and an invitation to be part of your seminar series. Really appreciate that. So today we want to talk about hamstring strain injuries. This is a body of work that my lab group has been involved with for quite some time. And we continue our work now with some of the funding that we've received of late from the NFL and some other few bodies. So we'll give you a chance to see some of the work that we're currently doing, as well as our findings up to this point. All right, disclosure slide. Okay, so when we're thinking about hamstring strain injuries, many of us have likely treated athletes with this injury or experienced it ourselves. Most commonly, it's associated with high-speed running, but depending on the sport, there are several other mechanisms that can be at play. Nonetheless, it tends to occur when the muscle is undergoing a large eccentric contraction, whether there's also involvement of external forces to the body or trunk position that may play a role. It tends to be one that is common in a lot of our professional sports and our higher level collegiate sports. And what makes this injury particularly challenging is the high rate of re-injury. So 20 years ago or so, the re-injury rates were reported at about 30%. Hopefully now, if we're using the most contemporary treatment strategies, we should see that down around 15 to 20%. But obviously that's even higher than we'd like to see. So what we want to talk about is how can we minimize that re-injury risk? Are there ways that we can identify deficits that persist at the time of return to play and better inform our return to play decision making? So when we look at the most of the rehab options that have been tested through randomized controlled trials, you'll see that majority of them do provide lower injury rates when they incorporate aspects of lengthening type exercises, or what we would think of as eccentric loading, as well as incorporate aspects of running into the rehab program. And again, we'll talk about how we can do that later in today's lecture. We know that if we just approach it in a very conventional way of stretching and strengthening and more traditional concentric strengthening type exercises, the re-injury rates are quite high. And so these are not approaches that are recommended at this time. They have been more or less moved to the side as strategies that are ineffective, or at least are not optimal compared to some of the more lengthening protocols or those that incorporate running into the rehab program. So when we think of our criteria for the rehab progression, right, obviously depending on the more acute within the first initial days, all the way up to that return to play, there are ways that we can guide that management or that progression using a criterion-based approach. Some of Rod Whiteley's work in BJSM from a few years ago suggests that there are 4 key indicators that can be useful to inform the progression, such as the length of palpation pain on the posterior thigh, the knee flexion strength at long muscle length, so knee angles of around 15 to 20 degrees, active knee extension test, but with the hip and maximum flexion, so thigh touching the chest, and then doing your active knee extension test. And then the athlete's self-report of pain during daily activity. Using those, he's found to be fairly useful in determining when you can progress intensity and load. Other examples that have been reported are on the right, where when you progress from more of a reduced load, limited range of motion sort of approach in phase 1, where you're really protecting the injury, to when you might advance it to more of a phase 2 of increased intensity, increased range of motion, and then back to your full sport specific tasks more toward phase 3. But when we look at our return to play decision making, again, based on those 3 trials to date, you'll notice that one area that is woefully underutilized is this idea of eccentric strength. That was not used as criteria in any of the RCTs to date. Most rely on an isometric form of measurement or a concentric form. And then, of course, you have more of the quality and assessments of movement, or even the running speed. And of course, athlete apprehension plays a role. But we know that the eccentric demand on the muscle plays a large role with the injury, and likely the re-injury, yet that remains an area that is not typically used as part of the return to play decision making. Not that people aren't doing it, we certainly are at this point as well, but the data to back it and support it, whether or not it's effective or not, is still a bit open-ended, and we'll provide some evidence toward that later in today's talk. So we think about factors that contribute to hamstring injury risk overall, not necessarily re-injury, but any injury. Certainly re-injury is included in this. There's a number of aspects that we need to think about, including obviously the athlete's strength themselves, how they're training, their level of fatigue overall, and then the demands of the sport itself, how much high-speed running, acceleration, deceleration, change of direction, and such. When we start thinking about re-injury risk, we also have to add in a number of factors that are present from the initial injury itself. So on the right-hand side of this slide, when we start looking at factors of persistent weakness from the injury, not just overall weakness of the muscle, but that's due to the injury itself, scar tissue that has been present from the injury itself, and then of course, how those might interact to alter the internal musculoskeletal dynamics during a particular task, such as running. So these are the areas that we've been trying to address here within our performance, our athlete performance program, known as Badger Athletic Performance. As Dr. Sell mentioned, this is a program that we've had now for just over a decade, and it really works well in terms of merging our academic side with our athletic side of campus. the uniquenesses of it in terms of our access, our full access to athletes, and the fact that our laboratory is embedded within UW Athletics in Camp Randall Stadium provides us a lot of access in terms of measurement and adherence to our measurement to be able to both help the student athlete as well as advance the science that we're using to both train and address these injuries. So what do we know at this point in terms of the biomechanics associated with running? When we look at the musculotendinous loads on the biceps femoris long head, for example, this is what it looks like during high speed running. So we have our stance phase over on this side of the plot, and swing phase. And what we can see is that there are two general peaks that occur in terms of load on the hamstring muscle during high speed running. And you'll note that the terminal swing load is very similar to the load during stance phase, right? So the inertial loads are considerable, even though there are no ground reaction forces on that limb at that time. But when we dig in further and start looking at the power that's occurring, the mechanical power or the mechanical work that's being done, you'll notice that during stance phase, it's largely a positive work, meaning we're dealing with a concentric loading mechanism. So the muscle is being loaded quite a bit and doing work, but it's working in a shortening manner, and it's working in a shorter range of motion or shorter length. It is when we look at this mid to terminal swing where we see the amount of negative work, that eccentric load in a longer length position, that starts to worry us in terms of some of these injuries. And this is akin to our biomechanical data that's been done with animals, showing the importance of negative work toward injury risk prediction of the muscle tendon unit. This is supported by some unique cases, in particular one that we were a part of. Thankfully, this wasn't part of our lab, it was measured elsewhere, but the video you're seeing was of an individual taking part in a research study who jumps off the treadmill because he tore his hamstring while he was taking part in that activity. So he was running fairly fast, I believe it was around 16 miles an hour on at the time of the injury. But what is unique about it is obviously he's healthy early on until he recognizes the injury and jumps off the treadmill. So this allowed us to go back, look at some of the basic kinematics, some of the joint torques during swing phase to see if there was any uniquenesses about his running style or in the strides that led up to the point where we knew the injury occurred. And what we're able to do is also narrow down to the window of when we expected, when was the highest probability of the injury to occur. And again, that supported terminal swing as the most likely time of injury. So at this point, we've got good biomechanical data. We've got a few unique cases that really indicate that terminal swing in the high speed running scenario is the most likely mechanism of injury. Now, when we start thinking about the effects of speed, this is also very enlightening in terms of, I think, how the injury may occur, but as importantly, how we need to incorporate this into our return to play progression for our athletes. And so we want to look at the effects of speed on running loads on the biceps femoris and on all the hamstring muscles, but we're going to highlight the biceps femoris long head here. And so obviously the risk of injury is greatest with higher running speeds. And so on the x-axis, you'll see that we have 80% all the way up to 100% of maximum sprinting speed. And we take measurements at every 5% increments. Now, the first thing we'll notice is that the length or the stretch of the muscle tendon unit of the hamstring doesn't change with running speed. The faster you run doesn't mean the muscle tendon unit is exposed to greater stretch. It's actually very much the same. However, when we look at the forces that are exposed to the muscle, and this is again focusing on swing phase, you'll see a very linear increase in forces that are generated by the biceps femoris. But more importantly is that amount of negative work. You'll notice that the negative work has an exponential increase. And so even though there's only, from 80 to 100% of running speed increase, there's approximately a 50% increase in negative work that the biceps femoris is exposed to. And that increase is similar across all the other hamstring muscles as well. So this is really critical in terms of how we progress speed and return to speed in our running athletes. If we train them a lot at 80% or 85% in rehab, and then expect them to jump back into 100% in practice fairly quickly without having that gradual acclimatization, you end up with this very large jump in loads and the potential for re-injury increases. And so the way we describe this to our athletes is to say, for example, if you're a 250-pound athlete and you're running at 80% of your maximum speed, the load on the hamstring muscles for that brief point of terminal swing, which again, we're talking about 5-10 milliseconds of time, ends up being about 265 pounds of force. If we increase the speed to 100%, now we have a jump to 335 pounds of force. And this helps the athlete to wrap their head around that jump or that increase in load that they're really experiencing with what they might perceive as a very small change in speed. And so when we think of our approach to hamstring strain into the rehab process itself, while we absolutely want to incorporate sprinting and speed work into our rehab, and we'll describe that shortly, we definitely want to have an emphasis early on with the many other forms of exercise that focus on other key components of the muscle recovery. So this was an open access paper that we recently published in Journal of Athletic Training. And I'm going to highlight a few pieces from it because we describe guidelines. This is not a protocol by any means, just guidelines and recommendations of a 3-stage progression, but also 3 categories of exercise. And our argument is that we want to incorporate at least 1 or 2 exercises from each category across the different stages of recovery. Importantly, in addition to that, we want to progress the range of motion from reduced range toward full range, but also still allow some level of pain. In other words, we use the approach of athlete tolerance versus pain-free. If we wait for pain-free, we may end up unnecessarily lengthening the time to recovery. And what we've seen is that when we incorporate an athlete tolerance with a maximum of 4 out of 10, we end up with a slightly faster progression, but more importantly, no adverse events that result from it. So we're not seeing any sort of an increased risk for re-injury during the rehab process. So what do some of these exercises look like? Again, these videos are all available online through the open access article. But for example, if we look at category 1, these are where we're going to focus heavily on eccentric knee flexors. So the eccentric load by manipulating the knee angle. So using things like a slider exercise where you put furniture movers underneath the heel. And you can progress it from bilateral to unilateral, as you'll see here, and then even up to a unilateral with load. But notice the number of repetitions that are done. We're not doing 3 sets of 10 or 3 sets of 12. They're only 4 to 6 reps. And again, it's the intensity is specific to the category, to the stage that they're in. So stage 1 is going to be more bilateral type exercise, lower intensity to the recovering muscle. Stage 2 is more full range of motion, progressing toward unilateral. And then stage 3 now becomes additional load on top of typical, and again, focusing much on some of the unilateral positions. So you'll see in a second here where we do a Nordic hamstring with additional load, in this case, a 45-pound plate. That's quite a bit, and that's not something that we necessarily want to do for everybody. We're selective in who we give it to. But nonetheless, the idea is that we really want to push the intensity and the load in that stage 3 level of recovery. Then we advance to a category 2, or our second category, rather. I shouldn't say we advance to it. We include a category 2 level from the beginning. This is focusing more on hip motion. So again, keeping the knee angle fairly stable and focusing more on increasing that hip flexion rather, and the associated moment arm with hip flexion. So again, we may limit the range of motion early on with stage 1. and then advance it as they're able to tolerate it without aggravating the injury. So typically up to the point at which they begin to feel a level of discomfort and or stretch. And then we can progress the exercises into different across the stages based on their recovery timeline. But again, the idea here is at any given stage, we have the different categories of exercise being represented. So all three categories are represented. And as importantly, you don't have to be at the same stage for all categories. So for example, category 1, which is our eccentric knee flexor load, we might advance to a stage 2 before our long hip extensor activity progresses to stage 2. That may still be at a stage 1. So we use this matrix arrangement to see where we're at and determine what the athlete tolerance is in terms of the different exercises that we're exposing them to. Eventually, when we get into stage 3 with this category 2, very heavy loads, again, through as much range of motion to the hip as possible, and making sure that you're incorporating even unilateral loads into that exercise. Again, the repetitions stay fairly low, 4, 6, 8 repetitions, maybe as high as 10, depending on the exercise, but generally only one set of each one of these. Even after the rehab completes, you want to continue these oftentimes during their early progression back to play. And then the final category we'll talk on briefly is the short hip extensor exercise. So these are more of a knee flexed posture while we're working on hip extension. So hip thrusts are a very common one. Stage 1, of course, you'd be doing it very early on, unloaded, just going through the range of motion. As you get into stage 2, you can start doing more unilateral work. And then, of course, stage 3, you start adding in more additional loads on top, whether it's, or even more speed work with it, like a plyometric unilateral hip thrust type of exercise. If you add an extra load, if you've done more in a bilateral setting to incorporate into the rehab process. So again, each category is represented throughout the rehab process. Now, one thing of note here is when we think about even those highest level of load exercises that we just described, you'll notice that the muscle activity that's generated during these exercises is quite a bit less than what happens during full sprinting. So these are EMG data that are shown for a variety of exercise across the x-axis. You'll see it represented for both the semitendinosus and more of a peach color in the biceps femoris and the blue. And you'll note that the white dot, think of that as your average or median, average rather, represents the average muscle activity during these different exercises. Nordics, upright hip extension, slow and fast, slide leg bridge, standing kick. Never does the average activity exceed 60% of what is experienced during sprinting. So if we want to get the athlete back to full sprinting, we need to think about incorporating sprinting itself or high-speed running into our rehab program. So at the same time as we're doing those exercises that we just described, we again have our 3 stages, stage 1, 2, and 3. We're also incorporating a running program and running progression as part of that recovery. So in stage 1, for example, we may, let's use 100-meter distance as our running distance. And again, that can be modified based on the sport. It can be adjusted depending on the size of the athlete, the position they play in the sport. But we have an acceleration period, a constant speed running, and then a deceleration period. And notice that during stage 1, our constant speed running really isn't getting much more than 50% of maximum speed. So it's not much more than a jog, but we want to expose them to that running as early as we can, provided they're able to tolerate it. Stage 2, we progress some intensity up to as high as about 80%, but it can be anywhere within that range from 50 to 80. And then finally, stage 3 is really when we take a very focused progression from 80 toward 100%, with the goal of we're not letting them back to play until they're very close to 100% of their comfortable sprinting speed. And much of this is self-gauged by the athlete. If you happen to have pre-injury sprint times, you can use those as a bit of a metric as well. But typically we go by self-report. And we know self-reported maximum sprinting speed after injury is less than what it was before the injury. So we have to factor that into our decision making as well as to when we feel they truly are at 100%. All right, the next thing we want to jump on a little bit is this value of eccentric load. So I think Dr. Sell mentioned that this was an active area of discussion of your group. So I'm happy to answer more questions on this as well. But these are data from our university football, soccer, and track teams over the last few years. Males and females are represented. The open circles are athletes that did not sustain a hamstring injury during the course of seasons, whereas those that are filled in, either red for the right side or blue for the left, did sustain a hamstring strain injury. And what we notice is that their baseline preseason eccentric strength during a Nordic activity was not able to predict those who went on to sustain the injury. If we used previously published cutoffs, for example, that shaded window down in that lower left corner, that is your high risk injury area based on published cutoffs. And unfortunately, that doesn't really work for our athletic population who have much stronger eccentric strength at baseline than the majority of those who would fall into that little window. Secondly, if you look at the asymmetry between limbs, greater than 15% asymmetry has been published. Well, again, most of our injuries happen well within that window. A few are outside of it, certainly, but not enough for it to have any real predictive value. So at this point, we generally don't use eccentric strength testing as a screening tool for injury risk. However, we absolutely do this as part of our regular preseason testing, more so to get a sense of what their baseline is, and two, to see if anybody really is down into this area of generally weak hamstrings that need to be addressed. But we're not using this as a screening tool for hamstring strain injury. And again, this is supported by a recent meta-analysis. David Opar is the lead author on this group and helped develop a lot of the momentum for using a Nordic curl as a screening tool. As lead author on saying it doesn't work as a predictive tool for future hamstring strain injury risk. And even if you decided to do repeat testing, not just preseason data, but repeat testing throughout the season, that doesn't improve its predictive value. So at this point, at least, it looks like eccentric strength testing as a predictor for hamstring injury risk is ineffective by itself. It doesn't mean it doesn't have a role in the total program, but at least as a one-off measurement is limited. So now when we start looking at the muscle injury and recovery itself, time of injury, of course, when you look at it on MRI, you see this classic feathering pattern, and this again involving the biceps femoris long. But even 3 months later, we continue to see a number of deficits that persist in that muscle, right? You still see some edema, scar tissue clearly is there. What does that look like in terms of the muscle's function overall? Well, the amount of edema that persists, excuse me, we've noted that about 20% of the muscle at the time they pass our criteria to return to play still shows edema, right? So still shows evidence of injury, still shows evidence of remodeling. Even though they have minimal to no pain with palpation, they have no apprehension, they're able to have full range of motion on the active knee test, they're sprinting at near maximum velocities, yet they're still showing signs of edema on scans. In addition, we know that there's evidence of scar tissue within a couple of months. And even when we look long-term, 6, 7 months in this case, but we've scanned individuals up to 2 years, 3 years after these injuries, and the scar tissue is essentially remains unchanged. So often to the point where the scar tendon volume, because oftentimes that scar is adjacent to that aponeurosis, where the muscle fascicles attach into it, will have almost a doubling in its volume or in its size compared to the contralateral side. When we look at muscle volume changes that can persist long-term after these hamstring injuries, Again, long head is one of the most commonly injured muscles with high speed running. And we typically see an atrophy that tends to persist. So up to about a 10-12% atrophy. However, the short head, we tend to see a hypertrophy. Now, these were some early volumetric measurements where we were doing, measuring serial axial slices and getting a whole muscle volume, and showing that there was a compensatory, what we felt was a compensatory hypertrophy of the short head. So what this indicates is that on your strength testing, on your common strength testing to the muscle, to the hamstring muscle, through applying a torque about the knee, it may show perfectly normal with the short head masking the long head weakness. We've since moved into other imaging protocols where we're able to use more AI approaches to segmenting the individual muscles. And consistently, we're seeing very similar changes with those who have sustained a long head injury, where we see the short head hypertrophying and the long head showing consistent atrophy. This happens to be a case in a professional baseball player who sustained these injuries, and we've now seen this consistently enough that it absolutely is an area that we are looking to target and make sure that we can maximize the recovery of the long head. We're also seeing fatty infiltration into the previously injured muscle. So let me back up to the slide. If you'll notice on the left image, you'll see where the white arrow is a little bit more marbling than we do on the opposite side. Now, again, this is something that we're seeing less consistently than the atrophy, but enough where we need to make note of it. And unfortunately, or fortunately, depending, it's not something that we tend to see in our younger athletes. And younger, I'm meaning like 25, 24 years of age and under. Once you're over that age, 25, 26, we start to see a little more of that fatty infiltration that tends to persist. And obviously, that's going to influence the quality of the muscle and the force production capabilities of that muscle. Even with all of those changes, fatty infiltrate, atrophy, scar tissue, when we look at their running mechanics, it looks like there's normal kinematic profiles of the muscle. In other words, they're not compensating in a way that protects the limb or causes the muscle to not lengthen as much. It appears that there is, at least in a side-to-side comparison, good symmetry in the running mechanics, would suggest two things. One, that these deficits really aren't manifesting in a limitation to high-speed running. Or two, the contralateral shot side is changing to match the limitations of the injured side. And this is some data that we've recently presented in abstract form and are currently working on a paper where we did have pre-injury running mechanics on athletes who went on to sustain a hamstring injury. And compared to their pre-injury data, what we found was that there was an increased reliance on the ankle torque production, ankle plantar flexure moment, compared to their pre-injury running style. So after the injury, when they were returned to play and tested in running mechanics, there tended to be more plantar flexion load or contribution. But more, as importantly, tends to be a shorter stride length. So when we think about that inertial load on the hamstring during terminal swing, this basically presents a way to protect that limb to some extent. So there may be that bilateral compensation where that healthy limb tends to match more of the injured limb. So this leads us into where we're heading right now with some of our current work. So this is a 4-year project that we're in about the beginning of year 2, a little ways into year 2, that we're trying to capture a more holistic understanding of what's happening before and after a hamstring strain injury. And my co-PIs in this project are Sylvia Blemker and David Opar. And we've got a number of collaborating institutions at this point, including BYU and University of North Carolina. AMSSM is our data coordinating center and is housing all of our information that allows us to look at allows us to compile the data from all these institutions and their football programs. So in short, what we're trying to do is develop a clinical predictive rule model that allows us to better capture all the factors that influence hamstring injury risk. We know strength has a role, but not by itself predictive enough. We know running mechanics have a role, but probably not by itself. The athlete demographics, age, history of injury, all of that is going to be important, as well as the muscle properties themselves, both in terms of size, tendon morphology, as well as architecture of the muscle. And so we're capturing these metrics on all of the FLOS football teams at baseline, preseason, during the summer months before they start camp. And then we begin to follow them for the occurrence of a hamstring strain injury. And once injured, we're again repeating our measurements to look to see what sort of characteristics of the injury itself, and then how did the structure and the function of the athlete and the muscle change following the injury. So we're going to measure all of these pieces again throughout the rehab process, and again at the time of return to play, to help us understand how that might contribute to re-injury risk. And then, of course, we'll repeat these again if a re-injury were to happen. In addition, we're documenting very diligently any use of orthobiologics, and that will allow us to do some case control comparison of athletes who did and did not have biologic injection for similar types of injuries with the same rehab program to see what effect that may or may not have had both on recovery of the muscle, but then potentially on re-injury and injury risk. So again, the idea behind it is that we will hopefully be able to roll out a clinical prediction risk framework for both injury and re-injury risk. This will also help to inform our return to sport guidance as to areas that we really want to target and make sure that they are fully recovered at the time of return to play, as well as provide objective criteria to minimize that re-injury risk. And then eventually be able to develop that injury mitigation program. It's one thing to identify factors that are critical to the re-injury process and the index injury. It's another to come up with a program that actually athletes can be adherent to and works within their sport training program to minimize that injury risk potential. So with that, again, the role of eccentrics and progressive high-speed running are critical to the rehab phase to both mitigate injury and re-injury risk. Many other factors are involved that we need to consider, and those are currently under investigation with our multi-site study right now. And we need to be thinking about changes in running mechanics, both from at the time of return to play that might not show up as an asymmetry, but might be different relative to their pre-injury status, making sure that that's not creating some level of a compromised performance and or future injury risk. I'd like to acknowledge all of our lab group members as part of this process and our alums, as well as our collaborators and external collaborators on this project. Thank you very much. Happy to take any questions that you may have.
Bryan, thank you. That was fantastic. Before we take any questions, I have posted in the chat, the meeting chat, a Word document that has some links to 2 podcasts on JOSPT's website that Dr. Heiderscheit was involved in. One is very recent. Posted a link to the open access article that Bryan referenced in Journal of Athletic Training. And at the end of his presentation, he mentioned the research group Hammer that is funded by the NFL to do injury prevention research and rehabilitation research. That's also an open access article, and I posted a link to that as well. And Bryan, I do want to say thank you for answering my question during your presentation. That was, I think that's an important thing for us to consider, and the idea that getting baseline information on individual demonstrates some of the importance of testing eccentric hamstring strength. I think Dr. Warren has a question.
I actually did. Thanks for trying to put me on the spot, but I actually did have a question. Bryan, that was outstanding. You touched on orthobiologics briefly toward the end when you were discussing the clinical rules you're looking to help develop. Without maybe going into too much specificity, are you seeing orthobiologics routinely associated with quicker recovery And is that something at the University of Wisconsin that you're frequently using to augment recovery?
Yeah, no, that's a great question. Thanks for that. Out of our 3 sites that we currently have, and we are onboarding a couple of other sites here over the next 6 months, there's quite a bit of variability, as you can imagine, in the use of orthobiologics. Here at University of Wisconsin, we don't use it frequently. We don't use it in the acute state. We tend to use it more if it's a lingering issue and the recovery is not going quite as planned. Then we may use it. Some other programs, excuse me, don't use it at all. However, one of the other sites, excuse me, that we're looking to potentially onboard use it quite a bit. In fact, they've said that they use it in about 90% of their acute hamstring injury cases right away from the beginning. So I'm actually kind of excited to potentially bring them on board, because that would give us a really great set of data to be able to see some of these changes. If you look in the published literature, other than some of the case series that have come out from a few clubs here and there showing, potentially faster return to play, there's a fair number of other studies, certainly in more of the international sports, that show no real value of it to both expediting return to play or minimizing re-injury risk. So it is a topic of debate for sure. And unfortunately, we don't have the data yet to be able to answer that.
No, that's
Thanks,
helpful.
Bryan. We have one
that. I was just gonna say real quick, anecdotally, just down here, there's great variability in our, collegiate partners and in our colleagues across the state and what they're doing both in the acute and chronic setting. So hopefully more to come and answer some of these questions. But thank you. Amazing talk too.
Oh, thank you. Appreciate that.
We have a question in the chat room from Olivia Abdu. For the rehab portion, what is the reason behind only performing one set of each exercise? And she also indicates, great presentation. Thank you.
Great. Well, thanks for that. And thanks for the question as well. The main reason is we don't want to, well, first off, it's a guide, right? So absolutely add an extra set if you choose that, if you think that it's going to be valuable to that individual athlete. But by having the 3 categories represented and the intensity of load that's being generated during each exercise, one set of each of those many times is going to be adequate to achieve the remodeling that's desirable. Now, that doesn't mean you wouldn't incorporate other exercises, right? For example, anything else you might want to do for core work or other conditioning type exercise that you may include as part of this, or agility type movements. Those can all be added in, and they certainly are, right? These are just those that are focused on maximizing the recovery of the injured muscle itself, but certainly will incorporate other ancillary exercises and movements into the total rehab program. And I should add on to it as well that the running itself is a tremendous load for these individuals, especially when you get up into that higher speed. So we don't want to think of it as we're doing these exercises that are really going to create a big load. I know, by the way, then we're going to run just to make it more of a running exercise. That running is a big load that needs to be factored in just as much as the Nordics or the other types of exercises.
Bryan, do a lot of your teams kind of preemptively or just do injury prevention and have these exercises as part of their preseason training or off-season training and how do you get athletes to do these when they're not necessarily at the University of Wisconsin?
Yeah, that's a great question. So our University of Wisconsin athletes, admittedly, they're like every place else. They're gonna choose not to do the work if they can get out of it. So a lot of them may not, especially if they have no history of the injury, right? It just doesn't resonate with them how critical it is. The ones that we absolutely do have best adherence to are those who have had a history of the injury. And at this point, we know that's probably our single best predictor of re-injury risk. So we query all the athletes coming in as freshmen. We try to get a profile of their high school injury history, and anybody who has this a hamstring strain injury is put on a program that very much targets it. Our strength coaches are fantastic and are up on the literature with us and incorporate a running program in the off season that has intensity with it. We know we need to keep intensity at 80, 90, 100% in the off season. It's not constantly, but at the right dosage, and they're very good at exposing them to it. And many times for the athlete, they can wrap their head around the run side of it, right? That's training. That's something that they don't want to do anyway. But keeping the fascicle length, which we really didn't even get into much on this talk, increased by having that heavy eccentric load just once a week is oftentimes enough to maintain it. You can see some really, really good effects from it. When they're not UW athletes, yeah, it's a challenge. We've had a number of athletes who come into our facility for testing purposes, who are from a number of other programs or professional league teams, and much of it is just education on what is a workable program for them that still addresses the needs that we have in terms of changing these pronounced muscle deficits. Yeah.
A couple questions from Will. You have a lot of great literature on running gait analysis biomechanics. Have you written any chapter articles or on sprinting gait analysis or biomechanics? I believe you have published some on sprinting gait analysis. You could, if you'd like, you can send those to me, or if you can provide those references now, that would be great.
Yeah, I'll send them to you. We've done quite a bit in the sprinting world, mainly on looking at loads on the hamstring, the kinematic, kinetic aspects of the hamstring muscles during high speed running, during sprinting. Not so much at the analysis side of it, not so much in terms of, oh, look at these measures, or on your 2D video, you want to highlight certain features of it. Haven't found that to be as valuable, at least in the hamstring injury world.
Just real quick, I'll post one of those. I see a link here to one called Sprinting Biomechanics and Hamstring Injuries. Is there a link, a literature review? That was in Sports Basal in 2021. Would that be a good reference?
Yeah, that is a good reference. That covers kind of the majority of them. If you want individual studies, happy to send you those as well.
And that is open access, I see, based on PubMed. Let's see. Here's another question. How much emphasis do you put on the individual's gait during the return to running progression? For instance, if their gait is altered, but they are pain-free, do you hold them at the current stage they are in until the gait is closer to baseline? And I assume that's, I don't know if that's running gait or sprinting gait or just gait, but I'll let you answer that question.
No, it's a good question. So I think in terms of their altered gait relative to baseline, we actually don't hold them back. Because really that's more of a self-limiting. They're limiting their running speed on both sides, and that, as much as anything, is a confidence, is a return exposure. And once we progress that side of it, we do see that the recovery takes place, and they do return to baseline naturally. I think we'd have a hard time directly telling them, giving them cues to resolve that sprinting limitation. If, however, they do show an asymmetry, I said before that most don't, and most don't. Every once in a while they do. And if they do show an asymmetry, then we hold them back. Then we're going to focus on very specific targeted work to address that asymmetry. And then, once that's resolved, we release in full. But if it's more of a self-limiting speed or stride length issue, the only way I'm going to get them to resolve that is to rebuild their confidence and gradually increase their running speed up, and it will work. It works quite well, but it's a time element.
Well, I think we can end there. I just want to note that we have representatives from a lot of different universities: Elon University, Ohio University. A colleague of mine and a good friend of mine from the University of Essex has been listening in as well. So we have some international representation: Wake Forest, Atrium, Winthrop as well. So I appreciate everyone attending. I assume you're attending because you probably have individuals you're taking care of right now. with this injury, or you know you have to focus on this injury moving forward. So with that, again, thank you very much, Dr. Heiderscheit, for your presentation this morning. Again, there's a lot of references in the chat room. If you're unable to get to those references, I can just email me directly, and I can send you those again, because I assume we'll turn this off, the Zoom off as well. And if you have any additional questions for Bryan, you can email those to me, and if Bryan, you don't mind, I'll just forward those to you as well.
Yeah, absolutely.
All right. Thank you very much. Perfect presentation for our groups here in Charlotte and the people that we work with. I'm very, very appreciative.
Great. Thank you all. Thanks for the opportunity. Really appreciate the questions.
Thank you.